growing up, because growing up is optional. That's kind of cute. Do not regret growing older. It's a privilege denied to many. Old age increases the likelihood of illness. Old folks tend to have more diseases, and as you get older, they intensify, and then eventually we all die. So there's a disproportionate number of self-administered and prescription drugs. And the data here is a bit old, but probably not a lot. The trend is the same. Elders account for at least 30% of prescriptions and 40% of over-the-counter meds, but only 13% of the US population. In the UK, 45% of prescriptions, but only 18% of the population. And in nursing homes, 97% in the past had received at least one prescription per year, and 71% in the community. So nursing homes tend to acquire more drugs as people get older. Why do side effects sometimes go unnoticed? And I think this is important, particularly when you're talking to your nursing staff, is that there are low health expectations. Sometimes you expect the elderly to have symptoms and to not be doing well. They're also perhaps less likely to complain. Cognitive impairment leads to less communication. They often rely upon the staff to talk to their physician or their provider, because we have a lot of non-physicians now working in nursing homes. Mistaken belief that symptoms may be just the effects of old age. And this is especially true for the anticholinergic side effects, which are among the most common drug-related effects in the elderly in nursing and assisted living facilities. So what does cholinergic mean? It's the parasympathetic and sympathetic nervous system both use acetylcholine as a neurotransmitter. And so here's the, you see carbon, carbon, oxygen, carbon, and then you have hydrogens out on the ends of some of these. Muscarinic receptors are named as such because they're more sensitive to muscarine than to nicotine, nicotinic acid, nicotine. So here is a mushroom from which muscarine was isolated. Isn't that cute? Probably not good to eat. And so the main components of the autonomic nervous system, just to keep in mind, the central nervous system has both parasympathetic and sympathetic. Then the parasympathetic uses acetylcholine and the preganglion nerves to the peripheral nerves. The acetylcholine is also used in the sympathetic nervous system. And out at the end organ, the parasympathetic still uses acetylcholine, where the sympathetic uses epinephrine, norepinephrine, etc. So here's a sort of a diagram of some of these terms. The nicotinic receptors are involved. You have also nicotinic receptors being used here. This is the extracellular fluid, and then the cytosol of the fluid in the peripheral cytoplasm, and then the membrane wall of the cell. So this just demonstrates the acetylcholine hitting these receptors and having effects take place on the inside of the cell. And this is an example of muscarinic receptors. So I'm going to give you some diagrams just to help remember how widespread these effects are. The parasympathetic nervous system comes out of the brain, affects pupils, lacrimal, salivary, heart, as in heart rate, lung, bronchoconstriction and dilatation, the stomach, pancreas, small intestine, the large intestine, the bladder, and reproductive organs. So here's another way of looking at, on the left, all the parasympathetic effects causing constriction of pupils, whereas sympathetic dilates the pupils. And so you start to see how some of these effects, when you're blocking some of these receptors, can affect organ function in the body, not just the brain, but the peripheral part of the body. So here's again another diagram showing the sympathetic comes out from the spinal cord, whereas the parasympathetic comes up higher and then down low for the bladder and bowel. So if you develop incontinence, sometimes it's a sign of impairment of the lower sacral spinal lumbar segments. So the geriatric effects of parasympathetic versus sympathetic, the fight or flight, or the rest and digest. So again, after a meal, what happens to you versus when you get a snake chasing you in the fight or flight technique. So again, nicotinic effects on acetylcholine, the muscarinic effects, and then norepinephrine and epinephrine effects. So elderly are more likely than young people to develop cognitive impairment from taking medications. They have a reduced capacity for homeostasis. You don't metabolize the drugs as well, you don't excrete them as well. Then there's already some intellectual decline in memory and learning from aging. And so the medications have a more pronounced effect on those brains. And so the medications that we need to know about are why we're giving this talk. So remember that some of the changes we see that are abrupt are actually delirium and most commonly associated syndrome to drug toxicity in the brain. So acute disturbance of higher cerebral function associated with impaired ability to attend to the environment. Onset is often rapid, fluctuating over a course of a day, or short-term memory and altered level of consciousness. And so it can affect the sleep-wake cycle, can cause hallucinations, delusions, psychomotor disturbances. You can have hyperactivity and hypoactivity forms of delirium. So presence of delirium in hospitals on admissions is 10 to 24%, and then it develops in an additional up to 32%. So some studies show that over 50% of hospitalized patients have delirium during their hospital stay. It is associated with a higher mortality rate and prolonged stays in the hospital. And it's also sometimes why they come back from the hospital on psychotropics. The hospital is trying to treat the symptoms rather than necessarily getting rid of the underlying cause. So instead of attending to blood sugar and hypoxia issues and drug side effects, they give another drug called a psychotropic. So dementia is a chronic confusional state, acquired loss of cognitive and emotional abilities. 1% of the population at age 60 and over 30% at age 85. You have the top two causes are Alzheimer's and then vascular disease. And these can be in combination, of course. Then you get into drug-induced confusion, which is one of the potentially treatable causes. If someone is on amiodarone and you aren't thinking about what it's doing to the brain, the thyroid, et cetera, you may miss an opportunity to improve their confusional state. So I'm talking about drug-induced cognitive. I'm going to move on down here. Drugs are found in the hospital to be causative agents in 10 to 30% of cases. Some cases are dose-related, while others are idiosyncratic. Polypharmacy is involved. So the more drugs you're on, the greater you have the chance of a delirium. And these were studies that looked at prospective studies. not retrospective, but this is a short list of drugs that in prospective studies were found to be causative of delirium. So I'm going to keep moving down here. The peripheral versus central anticholinergic effects. Peripheral, dry, sticky lips, difficulty beginning to speak, dental decay, troubles with dentures, painful chewing and swallowing, often leading to refusal of solid foods. Well, if you don't think about weight loss and they aren't eating well, and someone wants to put them on Boost or some other product, look at the med list and see if you can make an improvement by stopping some meds. Urinary disorders, often in males, lead to urine retention, anticholinergic effects, and BPH. Dry, pale, cool skin with loss of sweating is a peripheral manifestation. Insecure movement, falls without obvious cause. Look at the impaired muscular and coordination function from anticholinergics. Blurred vision, dilated pupils, anxiety with rapid shallow breathing, tachycardia, cardiac arrhythmias, memory deficits. All these can be due to effects of anticholinergic effects. So these are diseases which can clearly be made worse with anticholinergic drugs. Angina, heart failure, constipation, diabetes, and we'll get to why dexamethasone is mentioned here in a minute. Glaucoma, urinary dysfunction, sleep disturbance, dementia, poor vision, loss of accommodation. Now, Tooney and Ingley, back in the 90s, developed a serum assay for detecting anticholinergic properties of drugs. So this was first published all the way back in the 90s. And so you see dexamethasone is on the list down here. I just highlighted it in blue. And so that's one of the reasons why I mentioned that. It has anticholinergic effects. And so does prednisone. Keep in mind that these are mild effects, but if you get a lot of the mild effects cumulative, then you have as bad as one of the bad drugs. So chronic exposure to anticholinergic drugs, once you're on them for several years, the chances of cognitive decline, the cognitive decline gets worse over time if they're on multiple anticholinergic drugs. Drug burden index, this was out of Australian publications where they've done a lot of research on anticholinergic effects in Australia. And they showed over time that the drug burden index led to a loss of scores, a cognitive dysfunction. So in summary, anticholinergic use is common in the elderly. Even non-traditional drugs can have mild anticholinergic properties. So this is the more recent one, anticholinergic risk scale. And this gives you, and I'll show you the actual article in a moment, 3 points for this column of drugs, 2 points for this column, and 1 point for this column. And so even H2 blockers, ranitidine, has mild anticholinergic effects. Risperidol has mild. If you go all the way over to the other side, you're going to find that some of the other antipsychotics, perfenazine, etc., thiofixine, trifluperazine, can have much more. And intermediate are things like olanzapine and loratadine, clozapine, cimetidine. I don't know if any of you were medical school and training back in the 70s, but when cimetidine first came out, they started giving it like candy to stop GI bleeds, and patients became acutely confused in the hospitals with IV cimetidine. And so that was very quickly discovered, the delirium from the IV cimetidine. So this is the title of the article. It talks about the risk scale. The conclusion was that higher scores are associated with statistically significant increased risk of anticholinergic effects in older patients, and it was published quite a while ago in the Archives of Internal Medicine. And these are some of the data that they published in that study. And I'm going to move to another I'm going to try to, this is another list that has the drugs, anticholinergic drug burden scoring of a 1, a 2, or a 3, again showing by category skeletal muscle relaxants, antipsychotic meds, antidepressants, antihistamine, largely first generation, have the highest risk. GI antispasmodics, urinary anticholinergics, and drugs that we fortunately don't see much anymore, cogentin and artane, the brand names for trihexyl, phenanyl, and benztropine, are highly anticholinergic. And then the prototype drug of atropine. But again, this possible strategies are to start discontinuing medicines if possible, or reduce doses, or change to alternatives within the same drug class. This particular article had given a hypothetical patient who was on warfarin, receiving fentanyl, Tegretol, chlorpheniramine, Paxil, oxybutynin, had a total anticholinergic risk burden score of 13, very high. And so this just is another way of looking at this. Let me go to another reference, and I'm almost done. Now, we have heard from our CMDA about the Dr. Lineber, our pharmacy expert at the university, participated in the Beers drafting. And so this is table 7 from the 2023 Beers list, drugs with strong anticholinergic properties. Again, listing a lot of the antidepressants, antiemetics, antihistamines, the antimuscarinics. That's why I went over that thing at the beginning about muscarinic receptors being part of this. And some of these are older drugs now, but we still see oxybutynin as a preferred drug by a lot of health plans because it's so cheap. The anti-Parkinson's drugs we've mentioned, the antipsychotics I've mentioned, antispasmodic, these are drugs for the GI function. And then often overlooked, but skeletal muscle relaxants. And don't forget the cyclobenzaprine is almost identical to amitriptyline. If you look them up and look at their actual structure, it's about 1 hydrogen atom different between cyclobenzaprine and amitriptyline. And we get people put on Flexeril, that's cyclobenzaprine, and it's highly anticholinergic. So again, just things to keep in mind. And with that, I think I'm going to open it back up for any questions.
Yeah. Hey, Lee, before you finish, with the original Magellan anticholinergic risk score, they talked about scores of 3 or higher, and you've given us all the scoring, being high risk. And so do you want to touch on that? And I mean,
yeah,
synergistically just get worse.
Yeah, the article, the anticholinergic risk score, again, used scores of 3 or higher as being the highest risk group. And so let me share the screen again. So I know it's too small to see, but down here, they have the anticholinergic risk scores in this column, and 3 or greater had the highest adverse effects. So you could get to 3 with just 1 of the high-risk drugs, or you could get there with 3 of the low-risk drugs. And so that's the important thing to remember. In some of these hypothetical cases, take your drug list and go down these lists and figure it out. Are you at 13? Are you at 15? Are they having confusion? Are they being put on dietary supplements because they're having weight loss and dry mouth? So really attack the med list and work with your pharmacy colleagues to try to determine what are drugs that are high risk and which ones can you either substitute a lower risk drug in the same category or get rid of the drug entirely, which is my preference. So one example, Paxil is a good antidepressant. I think probably for young people, it has some roles, but in the elderly, it's the most anticholinergic of all the SSRIs. So it's not a real good drug for the elderly. So that's just one example where you could choose a drug, a different drug in the same category and have it be safer. So does that address, Greg, what you were thinking?
It is. Any questions for Lee before we move on to the next spot? Okay, then Travis, you're on.
All right, thank you. I'm having connectivity issues, so let me know if I have issues. So Dr. Gum asked me to talk a little bit about melatonin, something that we've talked about a fair amount. And I recently read an article that was put out by Dr. Peter Attia, and he has a podcast, and he's a pretty well-respected physician. And one of the things I think I appreciate is he does pretty deep dives into the topics. So in reviewing his review of melatonin, some of the highlights, and the first thing is that the use of melatonin has dramatically increased over the past, several years. Estimates are about maybe 150% increases year over year. So there is a lot more melatonin use. And I think one thing I appreciated was that, he went into how little melatonin the body actually produces. So the pineal gland produces the melatonin, and it can be measured in saliva or it can be measured in serum, but estimates are, anywhere around, just a few picograms per milliliter to up to maybe 40. And it increases, as the day goes on, and then the peak effect seems to be between 2 and 4 a.m. But a picogram is 1/1 trillionth of a milligram. So that's how little, that's how small the measurement is just to even measure the melatonin. And so that translates to anywhere between 0.1 milligram to 0.3 milligram in terms of the dosing in the supplements. And so, and it seems to be set genetically, and then it depletes over time. So that's the body's natural production. And the other big point is that because it's an unregulated, it's non-FDA approved, the supplement industry. So a recent JAMA study just this year published, and it looked at about 25 different over-the-counter sleep aids. Out of those sleep aids, one of them listed melatonin, but actually didn't have any in it. The other 24, only 3 of those 24 had melatonin anywhere basically within 10% of what its stated amount was. And so all the rest, 88% of them, the melatonin was as much as 340% off from what they said was in the ingredient. And it was actually typically over, so on the high end. So you're getting a lot of variation in the supplements. And the concern is that doses above 1 milligram, And keep in mind, 1 milligram, is literally 3 times on the high end what the body naturally produces. And so when you're talking about supplements that are that with that much variation, you are really risking that they're getting significantly more melatonin than what the body produces. And so, in essence, the recommendation was, if melatonin is used, it should be used sparingly and really not all the time. That the frequent use was a concern. And the only place it showed benefit was in jet lag. And so that there was actually some benefit seen there. Everywhere else, the benefit was pretty minimal. So I think when we're evaluating, how harmful is it above doses of 1 milligram, I think there's a decent amount of evidence to support that harm, partly because we don't know how much they're actually getting, and partly because of how much the body produces. So I would encourage everybody to take a look at the Peter Attia article, and we can send it out to everyone to take a look as well. That's it.
Yeah, I will send that out. And I haven't looked at everybody, but Jen Conley, are you on the call?
I am.
Jen, do you want to just throw in about 8-9 years ago, you taught us about a study that looked at, I think it was 100 assessment of 100 different melatonin prescriptions picked up at pharmacies around the country or Whole Food stores, whatever. And what was the most common ingredient?
Sawdust. True
Yeah.
story.
Yeah. Okay. So
And radish root is a common one too in there.
yeah. So it's just a reminder that, and actually, we're not going to get to the other stuff. We'll do it in December. But, these things that we use so commonly do have side effects and things that if you're not looking for them, you just won't see them or won't recognize that you're causing problems, which is why these two anticholinergics, melatonin, and the other stuff we're going to talk about really go together. Rebecca just asked a question. Let me see if I can get to it. Let's see.
Is there any recommendation on the need for tapering melatonin if at a high dose?
Yeah, you do have to. There is a withdrawal syndrome, so you do have to taper it. Like a lot of the other psychotropics we use, you can usually cut it. If I see people on as much as 12 milligrams a day, you can cut it in half about every 1 to 2 weeks until you get down to the 1 milligram. The CMS says that use of about 25% of folks over age 70 have a melatonin insufficiency, where it might be helpful if they have a sleep problem. If they don't have a sleep problem, don't use it. So for those folks, they say using it as a supplement is acceptable. But even then, 1 milligram is more than enough, as much as they need or more. So using 3 or 5 just because it's over the counter doesn't make sense.
Greg, a quick question.
Yeah.
Is 1 milligram for a surveyor a supplement and 3 milligrams is a prescription quote unquote drug that needs monitoring of sleep?
No, because actually, if they're under age 70, you got to monitor sleep because it's a sedative. Over age 70 is where it gets to be counted as a supplement. And it actually wasn't written into the regulations. It was the only place you can find it is in a FAQ memo that went out from CMS. So it's very difficult to find where you can actually use it as a supplement, but it is there. And they don't give a dose. They didn't step into that quagmire. For our Vivage Beacon buildings, I've stepped into that. And I really highly recommend not using more than 1 milligram. And if I see more than 3, I usually go ahead and go in and cut them back because the incidence of side effects goes up pretty dramatically over age 70 and over 3 milligrams.
And if you are a believer in giving it, what's the optimal time of day to give it?
In the evening, you want to give it probably a couple hours before bedtime, not right at bedtime, because it takes a while to get absorbed and kick in. All right. Anything else? And if not, we will just, I will tell you for next month, we're going to have it's going to be primarily about PCC and even more so about PCC in the Vivage Beacon facilities, because we have a wonderful woman named Darlene Dunn who does our PCC stuff, and they're working on some new templates. They're going to make a whole bunch of things easier for us in the dashboard to get to everybody that's been started on antibiotics in the past week quickly. Everybody started on psychotropics. Everybody would think it should make use of PCC easier. So she is going to take the entire half hour to walk people through that, to try to make your lives easier, is the hope. And then we will pick back up in December with trying to catch up on some of the odds and ends. And again, if you have questions, suggestions, thoughts, send them my way and we will get them included. That's it for today. Any questions? Thanks, everybody. Have a great month.
Thanks, everyone.
Thanks, everybody.